Welcome, everybody. Good afternoon and welcome. My name is Amanda Coventry-Verridge, and I'm Dying with Dignity Canada's Program Coordinator. Today, I'm joined by my colleague, Kelsey Goforth, our Director of Programs. Before we begin today, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and we invite and encourage you to do your own research regarding the various treaties, in particular the land in which you're on while meeting with us today. All right, so I'm very thrilled to welcome you today to our, again, first webinar back for the season. Through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before I welcome today's speakers, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as concise and clear as possible. And while we are going to try to get to as many audience questions as possible, unfortunately, we may not get to everyone. If you have any outstanding questions or concerns or questions that are quite personal in nature, please email us at support@dyingwithdignity.ca and we will follow up. Please note that this session will be recorded, so there's no need for you to take notes if you don't want to. There will also be a post-webinar survey that will pop up on your screen after the webinar and will give you the opportunity to share your feedback. So please stay around after the webinar is concluded. All right, and last but not least, before we introduce our speakers, I'd like to take a moment to spotlight an upcoming special project that will be premiering on World Right to Die Day this November 2nd. In My Own Time is a documentary that looks at what it means to die on one's own terms. Using firsthand accounts from people across Canada, this film will offer perspectives on medical assistance in dying less commonly seen in media reports and present an opportunity to educate people on end-of-life choice in Canada. So on November 2nd at 7 p.m. Eastern, Dying with Dignity Canada will be hosting the premiere of In My Own Time at Scotiabank Theatre in downtown Toronto. But don't worry, other screenings will be taking place across Canada throughout the month of November for this year, so be sure to follow us on social media for updates, and we hope you can join us. All right, let's go ahead and introduce our speakers for today's session. First and upmost, we have Sarah Cobb. Sarah's joining us as the Executive Director for Vancouver Hospice Society with many years of experience working in palliative care as well as end-of-life care. Passionate about person and family-centered care, Sarah led practice in the role of clinical nurse leader at St. Paul's Palliative Care Unit in Vancouver for over 10 years before joining VHS. And while in that role, she supported excellent patient and family-centered care, as well as supporting her palliative care program's Accreditation Canada process and many initiatives across the organization to improve access to end-of-life care. She has also been a member of the Vancouver End-of-Life Working Group since 2010, and she works hard to make a difference in the clinical and administrative practice of palliative care and feels honored to be in a leadership and advocacy role as executive director for VHS. So Sarah, thank you so much for joining us. And next up, we have the wonderful Liz Creel. Liz is a social worker who has worked with Casey House since 2005. Her clinical experience includes end-of-life care to individuals and their supports, bereavement support, individual counseling, substance use counseling, and advocacy with people living with or at risk of HIV and their families. In addition to her direct clinical work with clients, Liz has participated in numerous research initiatives, program development, and partnerships with organizations such as Maid House and the Alzheimer's Society of Toronto. And since 2017, she's taken an active role in the training and education of medical assistants in dying to Casey House staff and has even supported patients and their families through the MAID process. And last but not least, for 3 years, she has also served as the co-producer, writer, and host for the podcast Positively Speaking, which explores the experience of people living with HIV. So Liz, thank you so much for joining us today. And thank you so much to both of our speakers. I'm now going to go ahead and pass it off to Liz, who's going to start us off with a presentation. So she's going to deliver a PowerPoint for us, and then we're going to go ahead and pass the floor over to Kelsey, who's going to interview Sarah and ask some questions about the Will of Lovely Vancouver Hospice Society. So without further ado, I'm going to go ahead and pass it off to Liz.
Thanks so much, Amanda. Just give me a sec. I'm just going to share my screen. Okay, can everybody?
So that,
yeah,
I was just about to say that looks good. I can see the slides.
Excellent. Okay, great. Well, thank you so much, Amanda. Thank you for giving me the opportunity to speak about Casey House today. Really excited to be here. So Casey House, well, the agenda for today, I thought I'd give a brief history of Casey House. Bear with me if you've already aware of our services, but I thought it was important just to give a bit of the context of where we sit now. And I'm going to talk about our services and eligibility for services and supports for clients at end of life at Casey House. As well, I'm going to give a little case example of somebody that I worked with closely for about 1.5 years who had MAID here at Casey House. And I also had the privilege and honor of interviewing his name's Eric for our podcast, Positively Speaking, 2 days before his medical assisted death. So I just want to give a bit of a warning because it might be hard for some people, but it's a very powerful interview. I hope you'll enjoy it. And then obviously there'll be time for questions. So June Callwood and a group of social activists founded Casey House in 1988. June felt very, very strongly about young men dying of AIDS and being completely stigmatized. And her son, sadly, in 1982, Casey House is named after, died in a motorcycle accident and a drunk driver. And after that, she felt very, very committed to creating a space for young men to die with dignity. So in 1988, Casey House was born, and its location was at 9 Huntley Street in downtown Toronto. And her and the other founders really wanted to emphasize that it needed to be a very home-like environment, a place where people could come and feel comfort and love, because at that time, many young men, mostly, were dying alone and often in hospital and isolation. So this, for her, the emphasis needed to be on comfort. Casey House now, the former Casey House at 9 Huntley is now a Fife House program. Fife House provides housing for people living with HIV, and it's transitional housing. And it's really lovely that it's maintained the connection with HIV. And it's right across the street from our new building, which is located at 119 Isabella Street. And it's a much bigger building. It's over 50,000 square feet, and it houses our inpatient and our outpatient program. Although Casey House has evolved from a hospice, we're now a specialty hospital. We really have tried to maintain principles of and practices of hospice care. And so who do we serve? So we serve people with HIV, but we also serve people at risk of HIV. And that we broadened our scope in 2021 during the pandemic. We felt that it was really important to be able to provide support and safer injection sites and kits for people who were at risk for HIV. And those at risk were also due to the social determinants of health. So people who are identified as Indigenous, people experiencing negative impacts of substance use, racialized populations, including newcomers and refugees to Canada, people who have mental health concerns, men who have sex with men, as well as two-spirit and trans people who had sex with men, and people who had been previously incarcerated. Those people are all at higher risk of HIV. And many of the people that we work with are very low income, which is another risk factor. Our current caseload, we have 80% of our clients are living with HIV. 12% are HIV negative, and 9% have an unknown HIV diagnosis. And when people are intaked and don't want to know their status, we really do try to encourage them to get tested, because then we can start prevention early, and if they, starting HIV medications and that sort of thing. So that our scope gets broadened, I think, is really, really important. So we do a lot of HIV prevention, and as well as harm reduction. Harm reduction is a really big part of our programming. And again, we still, though, maintain our focus on palliative work, including MAID. We have an interdisciplinary team, and our approach is holistic. So depending on the client's needs, team members who are appropriate consult and collaborate together, all sort of with a harm reduction lens. And peer support is also a big part of our program. And we just strive to be as low barrier as possible and not judgmental. And both the inpatient and outpatient program hold weekly interdisciplinary meetings and discuss cases and collaborate. And that's a really important part of our practice. So our harm reduction services are, as I said, pretty integral to our programs. We were Ontario's first hospital-based supervised consumption site, which opened in August of 2021. And our outpatient program, SCS, opened in April 2022. And later that year, we opened Ontario's first supervised drug inhalation space, that in our outpatient program. And so we strive to be very low barrier. We provide safer supplies to the larger community and to our clients. People have access to harm reduction workers and peers, and we provide harm reduction training to staff and community members. And as you can see from the slide, we distribute over 100,000 safer drug kits per year. And Casey House is one of the only a small number of organizations that do provide safer drug kits to the larger community 24 hours a day, 7 days a week. Our outpatient care, so as I mentioned, we provide support to clients at risk and people living with HIV. Our interdisciplinary team provides client-centered care with a harm reduction focus. The team's made up of nurses, we have social worker, case managers, physiotherapist, pharmacist, nurse practitioner, mental health clinicians, massage therapists, rec therapists. I'm probably forgetting somebody. It's a big team. So it's great for clients that, with very client-centered. So depending on what their care needs are, they're connected to the appropriate clinician. And the program's open Monday to Friday, 9 to 5, with some evening appointments. We have, like I said, the nursing clinic, massage therapy, lots of programming, and of course, access to our supervised consumption site. We also have a midday meal that's a really nice way for people to gather and connect with each other and engage with staff, peers, volunteers, and each other. In our inpatient unit, we have 14 rooms, private rooms with washrooms and 24-hour nursing care and medical support. We provide support and end-of-life care to people. And for people coming in, they need to benefit, the criteria, they need to benefit from having an interdisciplinary team. They need to be 18 years of age or older. And admissions are based on medical priority, and palliative is always the top priority. And the length of stay is always based on the clinical need. We do have scheduled 2-week respite stays, and that can be for anything from caregiver relief or to start HIV medications or for support after a medical intervention that requires 24-hour care. The important thing too is that people need to want to be engaged with care and have goals that they want to achieve. One of the challenges that we're seeing a lot of recently, and many of you can probably relate, is many of our clients are unhoused, and we have a huge housing crisis here in Canada and in Toronto, as well as a shelter crisis. So discharging people off into the street has been a really huge challenge for us, as well as many other systemic issues. The inpatient team is comprised of occupational therapists, as you can see, physiotherapists, pharmacists. I mentioned all these disciplines for outpatient programs. So the difference is we have physicians and occupational therapists in our inpatient program. How to refer? So referrals can be done through our website, and we really emphasize the importance of having medical, including clear and specified medical goals, and including, if the person's in hospital, a hospital discharge summary, medication list, and demographic information. As much information as possible is really, really helpful. The last thing we want to do is have somebody, and it does happen sometimes, that arrives and really they're not sure why they're here. It might be more their community worker that wants them to be admitted more than they do. But it is really low barrier, and if you have questions, I can share my email, and feel free to contact me. So in terms of our end-of-life care, palliative doesn't necessarily mean end of life, as probably many of you know. We do often have people that are transferred from hospital or referred from hospital who are palliative, and sometimes the picture is different when they're admitted to Casey House. Maybe they're not really end of life, and they have the opportunity to work with our interdisciplinary team and maybe gain some strength, get their pain management under control, and if they have a home, return to the home for a short time. And they can choose to return to Casey House for end-of-life care if they choose, or stay at home for end-of-life care. And we define at Casey House end-of-life generally as less than 3 months, but it is a bit fluid. It's always very hard to really nail down, but generally less than 3 months. And as I mentioned earlier, we do prioritize our clients for admission who are end of life, and provide comfort measures, which I'll go into in a minute. We do have provide MAID here at Casey House. We don't admit people for MAID because there are other supports in the community, including MAID House in Toronto. But if somebody is admitted for end-of-life care and they are interested in having MAID, they can be assessed, have their 2 assessments, and we have a provider that can provide MAID at Casey House. Over the years, fewer of our clients are dying at Casey House. However, I will say during the pandemic, we seem to have lost a lot of our long-term clients. And it feels like sometimes deaths kind of come in waves, and it does feel like we have lost a lot of people during the pandemic, even though the numbers might not necessarily suggest that. So for the components of our end-of-life care, obviously physical comfort, pain management, symptom management is really, really important. Mental and emotional needs. So we do have a mental health team that can work with the person if they choose. We have a psychiatrist that visits once a week. We have mental health clinicians and social work that can provide mental and emotional support. Spiritual needs, again, this is all client focused. If somebody expresses a need to have some spiritual counseling, we can make arrangements for that to happen. Practical tasks, that can be anything from paperwork like powers of attorney, things like that, or just things around getting their rent paid or arranging for tasks to be done. We can help support that, and quality of life issues. One of the recent examples of kind of quality of life issues is one of our clients that was end of life came in and worked with our occupational therapist and physiotherapist. And his goal was to sit in his room, in his chair, and have coffee with his daughter. And it was really lovely that he was able to achieve that goal. And then I'll just talk briefly about social work, because that's my role. So I do work with the client, obviously, is my focus, and their support network, whatever that looks like, if it's their chosen family, their partner, friends. And my role is helping navigate often some, if there's tensions or dynamics, that's part of my role. I support people if they haven't done their power of attorney or will, we can support them to get that done, and funeral planning as well. Sometimes in terms of celebration of life, some people have a clear idea of what they'd like, and sometimes they just would like some support or brainstorming, and we can help with that. As well as legacy planning. Some people haven't really thought about it, and in discussing with them, maybe they decide to do some letter writing, make photo albums, or in the case of Eric, who I'm going to talk about in a minute, he really wanted to leave his legacy by recording this podcast and talking about his reasons for having MAID. So in terms of my work too, the challenge is I love my work because it's different every day, and also it can be really challenging. As I mentioned earlier, there's so many systemic issues that I think across the country people are facing, and it can be very, very, very hard in working with those issues, such as housing and shelter crisis, not enough mental health supports, and that sort of thing. We are lucky here at Casey House in the inpatient program because we can refer our clients who aren't already attached to our outpatient program. So at discharge, it's really great to know if when people come in and they don't have any sort of support in the community, we can refer them to our outpatient program for that support. In terms of MAID and other deaths at Casey House, one thing that we have really noticed, particularly, I think it came a lot to light during the pandemic when we were seeing a lot of our long-term clients die, is the need for regular debriefs. And I think we need to do more of it. But that's certainly something that has been identified, and we are doing more of. So deaths in the last year. So to date, we've had 19 deaths at Casey House. That's in the community program and in our inpatient unit. Last year, we had 22. And comparing that to the 1990s, when we were seeing 2 to 3 deaths a week. So it's changed hugely with medication. Fewer people are coming for end-of-life care, and a number of the people that have come for end-of-life care may not have known about MAID, and upon learning about it and have decided that they would like to be assessed and have gone forward with MAID. As well, we've had clients who have been assessed for MAID and have a date scheduled but have died before the procedure. We have a fantastic group of volunteers who have, since we opened, created beautiful quilts with the names of our clients who have died in our care that year. And every year it's a different quilt, it's a different design. They're really magical and they're beautiful. Quilts have long been a part of the AIDS movement, and the tradition started with the Names Project AIDS Memorial, and that was first displayed in 1987 in Washington, D.C. During the beginning of the pandemic, when many people weren't able to honor their loved ones, weren't able to have funerals, and this was a way to really honor them. At Casey House, we obviously need to get consent from the family members or the person themselves, and not every person has chosen to have their name because stigma, unfortunately, still does exist. And in those cases, there'd be just a blank square in place where their name should be. So this quilt, as you can see, is from 1994, and there are a lot of names on that quilt. The most recent quilt, which is a sneak peek, it's not really been released yet, is from 2020. And as you can see, there are far fewer, in this case, hearts representing people than there were in the early 90s. And the way we honor those of our clients who have died, we have a candle that's lit for 24 hours in June's Den. So it's a room on the main floor of Casey House named in honor of June Callwood, one of our founders, and a book of remembrance is available for people to sign. And we have our memorial quilts, they're rotated, and there's one always on display in that room. It's just absolutely beautiful. And then on World AIDS Day, December 1st every year, we have a service of remembrance where we invite family members, friends, and loved ones who have lost someone in the past year, and we read the names of those people who we have lost and have a gathering together. And during the pandemic, that was kind of tough because these were online. So I think last year was our first year that since the pandemic that we had in person, and we'll do that again this year. So I'm just going to talk briefly about Eric. He was a client who I worked very closely with for about a year and a half. He was 52 years old and HIV positive, diagnosed in 2005. He was diagnosed with ALS in 2016, and he lost the use of his arms, his upper extremities, and was completely dependent on others. And at the time when I met him, so that would have been about 2017, he would come to our day program lunch, our outpatient lunch program, and I was working both in that program and inpatient program at that time. And myself and other staff or volunteers would have to help him eat, feed him his lunch, help him make a phone call because he was completely dependent on others. And he kind of drew a line in the sand for himself. He decided that when he lost the use of his legs, that was when he would pursue MAID. So he was admitted to Casey House in October, 10 days before he died, before his scheduled MAID. He'd had all his assessments done in the community and had a date set. While he was at Casey House, he arranged to have a celebration of life offsite, and he had about 60 of his friends and family members, and he just talked about it with such emotion, and it was just an incredible experience for him. And I had the privilege and honor of interviewing him 2 days before his death on the podcast Positively Speaking, and he was very strong about wanting to record his story. He really felt that it would be helpful for people to understand his reasons for having MAID. He felt so strongly that having a date for MAID, even when I met him, just knowing that that was an option for him, he said improved his quality of life hugely. So I'm going to try to play 2 quick clips. I hope they work. Let me know if you can't hear them. The first clip starts very abruptly, so I apologize for that, but hopefully it's going to work, so I'm going to see.
Gave me such peace of mind, and it's been so good up until now. And part of the reason why it has been so good up until now is because I've known in the back of my mind that I will have control in the end. Not someone else, not this terrible disease, but I will. Yeah. And that's given me many more laughs and joyful moments of happiness than that I would not have otherwise had. Gave me such.
I'm sorry, I'm just going to try to advance the slide.
Eric died 2 days after this interview, on Wednesday, October 2nd, 2019. I had the privilege of being in Eric's room along with several of my colleagues. Eric was surrounded by family members and friends, and his partner was by his side. Eric had a beer, at his request, just prior to the procedure. His favorite music was playing, and a bouquet of flowers lay beside him on his pillow. As he looked around the room at his family members, friends, and partner, shortly before he died, Eric said, "I feel like I'm already in heaven." Eric died peacefully as he wished, bathed in love and tenderness.
So those are 2 short clips. Could people hear them, by the way? Oh, good. Okay. 2 short clips from the episode. That's the first episode in season 2. We have 2 seasons of Positively Speaking. And the podcast gives voices to people living with HIV and shares many different stories of people. They're all our clients. Or somehow connected to Casey House. So if you haven't heard it, I really encourage you to listen to it. You can find it wherever you listen to podcasts, or you can find it on our website as well. Also, this is a link to an article about another client who chose to have MAID at Casey House, and this gives his story. It's a very beautiful, compelling story. So if you have a chance or interested, have a look. And that's my presentation. Thank you so much for listening. And I guess we're doing questions at the end, however, Amanda, you want to do that. But thank you so much.
Thanks so much, Liz. That was a wonderful overview of all the incredible work that Casey House is doing, and some of the people that you've supported in your roles. So thank you so much for sharing that. And yes, speaking to Liz's point about questions, we would love to hear your questions. I know some are coming in already, so continue to send that in, and we will ask Liz and Sarah at the end. And with that said, I'm going to turn it over to Sarah, and we're going to do an interview to get more information about Vancouver Hospice Society and the work that Sarah and her team are doing. And Liz, if you want to take your slide down and stop sharing on your end. Oh, awesome, thank you. So to get started, Sarah, I'm wondering if you could tell us a little bit about why and how you got started in hospice care. And I know you touched on this, your bio touches on this a little bit, but any other information about what brought you on this journey? I think we'd love to hear that.
Yeah. Thank you. Yeah, so I started as a nurse over 20 years ago, and imagined myself in acute care, working in emergency and whatnot. And what I found very quickly in my career was I had almost no training about how to care for somebody at end of life. And so as I was facing patients who were dying, which anybody who works in healthcare will, I really didn't know what the best practice was. And after a few years, I realized that I thought, oh, I'll just go and learn how to provide really great end-of-life care, and then I'll go back to where I was working before. And here we are. I never left. It just became the most meaningful type of care that I think you can provide. And I think being able to truly care for people in a holistic fashion, thinking about all aspects of their life, is something that really shouldn't be limited to end-of-life care. It should really accompany people throughout any healthcare journey. But I feel proud to say that I think end-of-life care does that really well. And so, yeah, through my years, I just found myself working in end-of-life care, and now here at the Vancouver Hospice Society. So yeah, that's how I found myself doing this, and probably for the rest of my career.
Amazing, thank you. So just to give everyone a sense, a lot of us, don't have experience in hospices, or if we do, maybe we're there with a loved one for a brief period of time, and our experience was very much centered on that one person and that one experience. But could you share with us a little bit about what a typical day looks like for you and your team at the hospice?
Yeah, definitely. So I'll just back up a little bit. The Vancouver Hospice is one of 4 hospices supporting adults at end of life in Vancouver. We're located on the Musqueam, Squamish, and Tsleil-Waututh unceded territories. We are an 8-bed facility. It's been purpose-built. And then in total, there's 38 beds in total in Vancouver. So we are 8 of those beds. We run almost at full capacity year round. We see probably about 130 patients through those 8 beds in a year. So a typical day is all those 8 beds full, the clinical team meeting, that the families and friends and patients do become sort of quickly a part of the family. It's meant to be a home-like environment. It is a very homey space. We make all the food on site. We can kind of cater to people's specific requests, and we feel very fortunate to have such talented cooking staff here, because it does become a big part of what makes something feel good. So we're all here in support of those sort of 8 beds with patients and families and everything that comes with that. We also offer an extensive counseling and bereavement program that extends way beyond our walls. So that's the service that our organization provides to the community. We provide free individual counseling. We provide bereavement walks that are located around the city. We do that 7 times a year in different locations around Vancouver. And then we offer 12 different support groups to the community. We group people together based on kind of need. One of those is people who have lost somebody from MAID, but other groups include, we had a COVID loss support group. We have parental loss, spousal loss, adult child loss. Of course, there's an opioid crisis. I think across the country, and acutely in Vancouver, we feel that. And so looking for ways to support different communities who are grieving in different ways.
Thanks, Sarah. And the bereavement group, is that for, you mentioned the community, so is it for people who maybe didn't have somebody physically in the hospice, but people who died at home or in other places?
Yeah, we support anybody within Vancouver, but we do extend ourselves beyond Vancouver at times. But yeah, we're available to anybody. People can self-refer to us. Unlike the hospice beds, they do kind of go through community organizations, and people do get referred, whether it's from their family doctor, cancer agency, hospital, or community health unit. So that is the pathway into the hospice itself. But our counseling program is a self-referral process, and people can do that just through our website. They can look that up and see what services we offer and self-refer. Yeah.
Okay. Thank you. So for somebody who is physically within the hospice building, what type of care is provided? You mentioned, lots of acknowledging people's different dietary needs or preferences and, that sort of thing. Anything else that you wanted to highlight in terms of the care that's provided?
So I think hospice is a place where people receive palliative care, and palliative care is really a holistic approach to care focused on managing people's symptoms in a way that they direct us, right? So that doesn't look the same for everybody. So we have to really get to know people to understand what good quality end-of-life care means and looks like to them. For example, some people, are okay being, more sleepy if it means their pain is managed, whereas other people would be more content to endure a little bit more pain if it meant they were more awake. So these are just, the type of complex conversations that we have with people in order to ensure that we're meeting their goals. And each person truly has different goals. And so we have to be very sort of humble in approaching each patient that comes through our doors and understanding what sort of a good end of life looks like for them. Yeah, but we do have a team of nurses and doctors and social workers, counselors. We have music therapy at the hospice. We have healing touch. We have a tremendous group of volunteers. Volunteers built this facility. They are our founders. They spent 10 years fundraising to purpose build this site. And we're coming up next year on 10 years of being open at this location. So we are very fortunate to be incredibly well supported in the community. So all of those people contribute to the care that we provide.
That's wonderful. Yeah, very interesting that it was such a community project and just the wonderful impact that that's had over the years. So wonderful to see.
Yeah.
So Liz talked about this a little bit during her presentation about qualifying for hospice care. Is it the case at Vancouver Hospice Society that typically somebody has 3 months left in their life when they qualify for hospice care, or are there differences?
Yeah, it's interesting. It's quite similar. I think I heard Liz say some of the same things that like really we've been trying to get away from a timeline because it is very difficult to estimate. I would say our criteria is anybody with a life-limiting diagnosis of any kind that is in their final weeks to months of life approximately. It is meant to be sort of short stay. We just simply don't have enough beds for people to be able to come and stay for extended periods. But also who need this type of specialized care, right? If the care can be provided at home and supported, and that's where somebody wants to die, then that's where the efforts of the healthcare system are focused. So it's really needs-based. But certainly in the final sort of weeks to months of life is generally our criteria. Yeah.
Thank you. And you mentioned too that for some of the programs that are more community-based, like the bereavement piece, that it's self-referral and people can kind of sign up based on what those needs are that they have. But for the beds in the hospice, that's usually coming from another agency or a doctor or somebody is making that referral. Am I understanding that part correctly, Sarah?
Yeah, in Vancouver, and I think some of the other health authorities in BC, the hospice beds are managed through a central referral line. So we have something called the palliative access line, and they manage the beds in the acute care in the hospitals, the palliative care units, as well as liaising with all the home care nurses who support each health unit throughout the city, and then the 4 hospices. So it's a coordinated system to try to prioritize people in need, and making sure home care nurses aren't phoning like all over the place. They can phone one central place to find out where the patient or family or client in the community that needs care can access it. So it is pretty streamlined in terms of access. But yeah, it is through some providers. Certainly people do call us directly to say, how can I access this care? And we'll guide them through that. So happy to do that as well. Yeah.
And do people, when hospice seems like it may be a good fit for them, do you find that people are usually raising that themselves with their clinician or agency, or is it usually something that kind of comes up from the clinician and as a potential space for someone to go at that stage in their life?
Such a good question. I mean, I think this speaks to the bigger, maybe larger state of sort of palliative care, probably across the country, is that I think we're not embedding it early enough and soon enough in people's care. I think the new sort of language is around the palliative approach to care, which really should be introduced at any diagnosis of any life-limiting condition, and it should be adapted and adopted and sort of embedded throughout somebody's end of life, or sometimes that's many years. So palliative care really should accompany people on any sort of journey, but unfortunately it does tend to get introduced right at the end of people's lives. So I think hospice, sometimes people know about it because they have had a family experience or they've previous experience. Some people do know about it just without having had experience, but I find a lot of the feedback that we get was sort of wishing they had known about hospice maybe sooner, because sometimes we do get quite late referrals, and people maybe don't get to experience the full benefit of what a palliative approach might have offered them. So hopefully that answers that question.
Yeah, for sure. And I think your answer really speaks to some of those myths too. People hear palliative care and assume, are we just stopping everything? And am I going to die in a week? And what does this mean? And it might be, there's so many misconceptions about what that means. And
So
I
many
think,
misconceptions, yeah.
yeah,
I
absolutely.
think, and there are some studies that us palliative care folks like to cite where that the earlier involvement of palliative care really does actually help people live longer. I think if you're emotional, your psychological, like if your whole self is being cared for and has the opportunity to express yourself and be well cared for, it stands to reason that you would do better.
Mm-hmm.
And so earlier is better.
Sure. Thank you. I think this leads to our next question quite well, about just terminology and misconceptions and what different things mean. Can you speak to the differences and similarities between hospice care and palliative care, and what those two terms mean and when they're used?
I think some people do use them interchangeably, like they will say hospice palliative care, like, you can hear home hospice. So, in our case, we are a physical hospice, like the building itself is a hospice. But the care we deliver is palliative care. It's support symptom management. So, I think if you were to look at the US, they may have a different definition. Hospice care is more of a program, but again, it depends on what community you live in. But palliative care is really the broad term, I would say, of the overall type of care that's delivered. And then hospice can be a location, but of course you can receive hospice palliative care anywhere. But there are physical buildings that are hospices, of course. But I think palliative care is sort of the type of care that's delivered regardless of setting.
Thank you. So you shared with us a little bit about Vancouver Hospice Society's origins and this very community-based initiative to get the hospice running, and years of effort put in to get this this project going and these services out there for the community. Is there anything else you wanted to share with the audience today about some of the hospice's mission and services and supports, or if people, leave the webinar today and have questions later, where they can go to get more information?
Yeah, absolutely. I mean, our website, vancouverhospice.org, has plenty of information about our services. I think, our mission is really providing compassionate end-of-life care and including bereavement services. We are partially funded by our local health authority. So in terms of the 8 beds, we do receive some funding, but the rest of our organization, in terms of the counseling, like that is fundraised for by this organization. And I think it would be nice to see more advocacy and recognizing that bereavement care really is a part of primary care as well. So it would be nice to see some changes over time, and not just the direct patient care while somebody's alive being recognized as critical, but of course the care that continues after somebody loses somebody. I think the other thing to say, yeah, maybe there's probably more that may come up through questions, but just I lost my other thought there.
That's okay. No worries. So moving on a little bit to what the hospice care experience looks like, palliative care experience at end of life. When it comes to prioritizing a patient's end-of-life wishes and priorities, how does one go about sort of discovering what those priorities and wishes are and incorporating them into the care that's received? What does that process typically look like?
I think it starts before they get here, in the referral process. So understanding a little bit about who somebody is from the team that's referring them. And then, of course, when somebody arrives here, it's really part of our intake to understand who somebody is. So we have sort of one whole page dedicated to getting to know, like, who are you, what matters? And then, of course, that prompts a conversation. Of course, we have people from many different backgrounds and many different cultures. So often we're doing this through interpreter services. So, just really making sure we know what's important to some people, because you can't assume that it's the same for everyone. And then just letting people know that, within reason, like, this is their home, right? And so ensuring that if they want to bring food from home, they bring food from home. If they want to go out for lunch, if they're able, with their family, like, go, like, live life. Like, this is hospice and end of life care, to my mind, is very much about living. And so what does that mean for each person that comes here, and how can we support them to achieve that? So it really truly is different for everybody. And so just keeping our assumptions and biases in check, and just making sure we do a good job of getting to know people and introducing them to what we have available, but then, of course, encouraging them to access, bring family and friends in to celebrate. And as Liz said, we have a lot of celebrations here and gatherings. And so, yeah, I think that's it. Just getting to know people and understanding what that is for each person.
Thanks, Sarah. So this next question, kind of interesting, moving into this one after your answer, because you just shared how, how we're looking at a person as an individual and everything that makes them who they are and what they might want and how they're going to choose to spend their time. So this question is asking about any commonalities that you have encountered in your work at the hospice when it comes to those receiving care, and if there are any similarities that you see as people reflect on their life and their needs at end of life.
Mm-hmm. I think for a lot of people, I mean, this is not a lot of people are hoping or wishing that they worked more or did those kind of things. I think people are really focused on family or friends or chosen family, whoever that may be. And, I find, honestly, by the time people come to hospice, they are quite far into their illness trajectory these days. And so people have little energy, and so how they use that time and energy does tend to be focused on spending time with people they care about, and can be quite introspective time, I find. But yeah, I think the commonalities are just people and connection and memories. And, I think sometimes there is a sense of, I think to some degree we live in a death denying culture. And so I think the more we can do to open the dialogue about death being a natural part of life earlier, and sort of incorporating that into our society, I think the better, because there are people who really, truly, sometimes after years of living with like a life-limiting diagnosis, are really surprised to find themselves dying. And I do sometimes wonder if we're denying people this opportunity to live more fully with that knowledge. But yeah, and the idea that people all accept their death is not true, or people don't all come to some happy, peaceful place, and that's okay. We just have to be there to support people on whatever their journey is. And depending on where you're at in your life, if sometimes if you're younger, the pain is quite different, but equally at 90 you can still feel like you have decades of life ahead of you. So that's where it comes back to that sort of individual, everybody's different, but yeah, it's hard to say.
Thanks, Sarah. So we touched on bereavement supports already. One question I find that comes up a lot for people who are working with people who are at end of life or planning for what they might want at end of life, whenever that may be, is questions about grief and any feelings that a person might have working in that environment and seeing people reach the end of their lives. How do you manage grief in the workplace, both for yourself, your team, and for patients and their families?
So we do have some rituals similar to what Liz described. We have a little memorial area at the hospice. We light a light every time someone passes, and we do as a team try to connect and reflect on people who do die at the hospice. We probably see closer to like 130 odd deaths in the hospice every year. So we try to connect as a team. We debrief as a team every week. We meet outside of work to provide education, trauma-informed care, self-care, reflecting on the different sort of cultural practices and beliefs that come up that may impact the grieving trajectory. So those are some of the ways we support our team, as well as social activities and connection outside of work. And then, of course, our bereavement program is any family member that comes through our hospice gets a follow-up call from our counseling team. And we also send them a card to acknowledge their loss, along with other resources. We also, any of the programs we offer are available to any of the families that have come through the hospice. And yeah, we try to do our best. We also try to offer some public grieving sessions. Last year over Christmas, we did a grieving over the holidays, open invitation to people to come and it was part psychoeducational, like how do I cope at these times where your loss may feel more prominent when families are all gathering and whatnot, and then part just remembering. And we used a little bit of art therapy, music therapy to bring people together. So there's also an educational component out in the community. I think now people are coming to terms with the fact that grief isn't something you process and get over. You just learn to adapt and live with grief. So also just trying to support people. A lot of what we do in our bereavement counseling sessions is normalizing grief, because I think along with our death literacy, it's also grief literacy. Like people don't know what's normal. And they expect things to be linear when in fact they couldn't be farther from it. So education, support, encouragement, anything we can do to support people, both staff and our community.
Thanks, Sarah. Yeah, those are such good points about death and grief literacy, and again, just lots of misconceptions about what that can look like. So one more question for you, Sarah, before we go to our audience questions. Are there any lessons that you've learned in your, I mean, you've mentioned some already, but any further lessons that you want to share with the group that you learned in your role at VHC?
I think, you know, we're all going to die. And I think the more that we incorporate that knowledge sort of into our daily lives, I think it doesn't have to overwhelm us, but I think it benefits us all. And I really hope to see more education in schools, in medical training, in professions like that, so that people can have better access. I think in terms of Canadians' access to quality palliative end-of-life care across the spectrum, it's still quite limited. Like, people really don't have good access. So I'd really would love to see Canadians have better access to end-of-life palliative care. That would be my sort of biggest wish, I guess, is that people receive access to quality care at their end of life, however they want it.
Thanks so much, Sarah. So as mentioned to the audience, we're now going to open it up to some of those questions that you sent in ahead of time or live during the session today for both Liz and Sarah. So I'll start by just asking one of you, and if the other person wants to jump in and add anything, please go ahead. So this first question is, I think, a really great one. Do either of your facilities offer any animal-based therapy, any pets coming in? Liz, do you want to get us started with that one?
Sure, we do have pet therapy. We have it sort of come and gone, especially during the pandemic, but I think it's back now, and it's such an important therapy. We almost had a therapy horse. I'm just going to say it was a miniature horse, but that didn't work out, but we're still working on it. But generally we have had dogs, therapy dogs, and it is amazing how it just brightens. Even somebody that is very quiet just can brighten up their face. So yes, I'd like to see more of it, I must say.
Thanks, Liz. Sarah?
Yeah, it's similar here. A lot of dogs, and of course we encourage people to bring their own pets in as well. So that's we've had some cats over the years, but it is mostly tend to be dogs, and a lot of the staff here have dogs as well. So they make guest appearances. So yeah, animals and anything that sort of brings life and comfort. And I would say that also supports the staff as much as the patients and families.
Okay, thank you. So one of our very generous attendees today has a question about how they can give back to the hospice communities. So this person is asking about different ways to get involved in hospice care and volunteering, what types of programs that are offered for volunteers. So any comments on that? Sarah, do you want to get started?
Sure. So locally in Vancouver, you know, volunteering for the hospice, we're always taking new volunteers to support our different programs. We also have 2 incredible thrift stores. So in Vancouver, selling some amazing, incredible donations from our community. So you can sort of support us through those stores, or donating, or signing up to be a volunteer at whatever your local hospice organization may be. We also have a provincial BC Hospice Palliative Care Association, which advocates on behalf of the hospices and not-for-profits in BC. So they're also a very worthy cause to support in terms of supporting all hospices in British Columbia. But I would say connect with your local hospice. They're almost certainly accepting volunteers or donations, or even just spreading the word on different programs that we offer.
Sarah, yes?
Yeah, we do. We have an extensive volunteer program with training. We have, as I mentioned earlier, we have this group of amazing volunteers that have been doing the quilts over the years. We have volunteers that are specific to our events. And I'm sure I'm missing some other volunteers. In terms of provincially, I couldn't speak about that, but I know we do have a provincial hike for hospices across Ontario that we don't participate in, but I know that's a way that people like to participate. Yeah.
Thanks, Liz. So there's a question about, and again, this kind of goes back to what you and I were talking about, Sarah, but palliative care being provided in various different settings. So this question is about the difference between palliative care being provided in a palliative care unit in a large hospital that provides all sorts of care versus palliative care being provided in a dedicated hospice space. Are there any differences that either of you would like to highlight, or any comments on how these programs might look different or the same?
I think as we see people live a lot longer with different diagnoses and the opportunities for treatment are, perhaps carry on much longer, like even though your diagnosis may still be life limiting and not have a cure, your ability to live with that illness may be vastly extended. And therefore, the symptom burden may also increase during that time. So palliative care units in hospitals, at least in Vancouver, tend to focus on the more acute symptom management and stabilization, with the view of then hopefully being discharged home or possibly to hospice or long-term care or wherever the most suitable place is for your care. So there's sort of more of, I would say, stabilization of acute symptoms with the view of transferring. That's not to say many people don't have their end of life in hospitals on palliative care units. They certainly do. But that's what it's like in Vancouver anyway. The palliative care units would be more acute symptom focus, management, stabilization, with the view of then discharging back to the community in the appropriate setting.
Thanks, Sarah. Liz, is that anything to add to that, or is that about the same?
I don't actually know. I mean, I certainly am familiar with some hospices where it seems like the people that are admitted are really close to end of life and die in that setting. Whereas hospices are more kind of what Sarah, you were talking about. It's kind of a bit fluid, like it can be 3 months or less. Some hospices or some hospitals may do sort of discharge people to home if they want to die at home. We do have a home hospice care program that maybe some people are discharged from hospital, but when they come to us, it would be for end of life care, or if they, again, if they want to return home to die at home. So that didn't really, does that make sense? I think it's probably similar. I just don't know for all the hospitals in Toronto.
Thank you. So there's a question about coverage of these services. So is there a cost for people who might want to go to either Casey House or Vancouver Hospice Society, or is this something that's covered through private insurance, through your employer, for instance, or through the government's, like the provincial health insurance coverage?
So our beds are heavily subsidized, but there is a fee. It's $43.98 a day that the family or patient has to pay. However, cost is never a barrier. It's always a sliding scale. So it could be from $0 to the full amount. It's not a barrier to access.
Thanks, Sarah. And Liz?
Yeah, there's no cost for our services at all. People are often covered by our provincial healthcare, but we also have uninsured people that have no coverage, but there's no charge.
Thank you. And another question about wait lists. So, and Sarah, you mentioned the number of beds in Vancouver in general. I forget what you said. Was it
38 beds?
38 beds in total, yeah. And Liz, I forget how many beds you said you have at Casey House.
14.
14.
Yeah.
So what types of wait lists do do you often experience either at your facilities in particular or in your cities more generally? Is the wait list often quite significant?
For us, we're quite centrally located, and so I think for our 8 beds out of those 38, we typically have anywhere from 2 to 3 people waiting at a time, and so people can wait anywhere from days to weeks to get a bed here. And then more broadly in the community, yeah, they all run a pretty high occupancy. We do have one hospice that supports primarily the downtown east side of Vancouver, which is where we have a large sort of more unhoused population. So that is their sort of area of focus. But in general, most of the hospices run a pretty high occupancy rate.
And in terms of Casey House, yeah, right, we have a wait list. It really ebbs and flows. But I'd say over the last year, it's been pretty close to full occupancy with a wait list. I can't really speak of other hospices.
No worries. Thanks, Liz. So we're getting near the end of our time together today, but we have time for maybe a couple more questions. So if somebody is asking about legacy planning, I love this question as well. Do you offer people help or suggestions when it comes to legacy planning? Any sort of end of life projects that somebody might want to do to pass down to loved ones? Is that something that happens often in the space? And do you have any examples? Liz, do you want to get started?
Sure. I mentioned there have been a number of clients who've been interested in creating photo journals for their family members or letters or letter writing, and the podcast, that was something that was really special to Eric. So it's very dependent on the person. Sometimes people don't choose to, but yeah, we'll work with the person. Sometimes our rec therapists will support that if the person is needing a little bit of a nudge. Yeah.
Thanks, Liz. Sarah?
Yeah, I would say similar. We support people. Music therapy often prompts a lot of memories and sharing. And in fact, it wasn't at our hospice, but our music therapist actually wrote a number of songs with a patient and recorded them for him. So that was a pretty special gift that he was able to leave for his family. There is also like a lot of work in Canada around like dignity therapy, like Harvey Chochnov is a big name in the country. So I think it's something we need to lean into more. There's also a lot of apps out there these days where people can record different stories and memories for people, and even just voice recordings and oral histories, like encourage people to do that kind of thing. But I think we could always do more in this area.
For sure. Yeah, lots of books and things with prompts to fill in and reflect on your life. Lots of interesting tools out there now. So one last question before we wrap up. A couple people have actually asked about end-of-life doulas or death doulas, and a bit of a growing movement in Canada and elsewhere in that space. Do you have any comments on how end-of-life doulas might be involved in your facilities or in end-of-life care more generally? Sarah?
I jump in. So yeah, I think it's great that a lot of people are taking an interest in end of life and engaging and learning more. We've actually had tons of death doulas apply to be volunteers at the hospice, which has really been phenomenal. And you know, some of them are doing other work in the community around death cafes and these other kinds of things. So I think it's all about having that conversation with our community, and I think death doulas are definitely a part of that. I believe we don't have a death doula that works with or at the hospice, but if people are using that support, they absolutely can incorporate that into the care here, and we would welcome that.
Yeah, thanks. Liz?
Yeah, similarly to Sarah, we don't currently have a death doula, but I think it is a fantastic approach, and I think we're hearing more about it. And I think, as Sarah said, we have to talk more about death, and I think having a death doula, we may have death doulas on our volunteer program, and I'm not sure, but I think it's really important to be talking more about it for sure.
Great, thank you. So I think we're out of time for today, unfortunately, but I wanted to thank Liz and Sarah both so much for being with us today and sharing more about their experiences and the amazing work that they're doing, that their teams are doing at Vancouver Hospice Society and Casey House. And thank you to our wonderful audience for being so engaged and asking so many great questions today. Webinars like this one and all of our other compassionate services are provided free of charge for Canadians navigating end of life, their loved ones, and their healthcare providers. To enable us to continue providing these services, please consider making a charitable donation. We'll put the link in the chat if you are interested in doing so. I also wanted to flag that this is just the beginning of many webinars that we have coming up this fall. We're so excited to be back from a little bit of a break this summer and now have a full schedule for everybody over the next couple months. So do check out our website. We have another session coming up next week. And if you haven't registered, there's still lots of room to have you join us then. Thank you again, everyone, for being here today, and have a pleasant afternoon. Bye-bye.